My name is Daniela Labate. I'm with NIAPRIS. So I see lots of folks are still logging on, but in the interest of time, we're going to get started. And we are very happy to see so many of you joining us today for part 2 in our outcome series. Before we get started, I'd like to go over a few housekeeping items with you. Today's webinar is being recorded, and the slides from today's presentation, along with the recording, will be posted on the MCTAC website. And we do encourage you to use the chat box and type in your questions throughout the webinar today. We've set aside some time at the end for Q&A, so feel free to type in at any point during the presentation. Okay, so what is MCTAC? MCTAC offers training and technical assistance to mental health and substance use disorder providers throughout New York State, and MCTAC's overall goal is to assist providers in the transition to Medicaid managed care. So this slide shows you all of the MCTAC partners, and this slide shows you all of the Small Business Initiative partners. And the Small Business Initiative partners work specifically with providers in the transition to Medicaid managed care who have no experience billing Medicaid or less experience billing Medicaid. Okay, so I'm pleased to introduce back with us today David Worsnick from CCSI. He'll be with us throughout the entire webinar series. And we also have Ashley Futz from MCTAC with us. And David and Ashley are the data gurus from CCSI and MCTAC, so I want to welcome them and thank them for presenting today. And just a little quick plug for the rest of the series. Today's the second webinar in our series. The next 2 webinars will be held from noon to 1 p.m. on April 19th and May 3rd. The next webinar will show you all of the wonders of Excel and how to use Excel to work with your data. And then the last webinar in this series pulls everything together from the previous webinars and will discuss how to use data to make decisions that not only will inform practice but also help empower your staff. So just another quick reminder, please do use the chat box to type in your questions to all panelists throughout the presentation. And with that being said, I am going to pass the presenter ball over to Ashley, who is going to get us started. So welcome, Ashley and David.
Great, thank you, Daniela. So hi, everyone. Thank you again for joining today's webinar. So for today's agenda, we're going to cover 3 main things. The first thing we're going to talk about is where to start and how you an example of how you can look at your existing data. Then we'll go through the anatomy of an outcome measure, and then we'll walk through an example of how you can build your outcome measure. So where to start? So once you have determined your outcome measures, the first step is to review the reports and data you already can get out of your EHR or billing system. Look at your reports that can help you better understand the consumers you serve, the types and scopes of services you provide, and the payers you will be accountable to. So there's the main takeaway from this slide, is that often when we think about outcomes and collecting data, we think about collecting new sources of data. But I really just want to highlight that often a good place for us to start is to look at the data that we're already collecting at our agency, whether it's through your billing system or your EHR. And using all that data that we already have, we can answer some important questions. So this is an example, and some of you may have heard of this project before, so if you have, I apologize. So through a grant with the New York State Health Foundation, MCTAC and CTAC partnered with the McSilver Institute to develop a pair of standardized reports that are now integrated within organizations' EHR using existing data. So this project was a collaboration of 7 large New York State agencies, as well as 4 EHR vendors, which included NetSmart, Foothold, Acumedic, and IMA. The 2 reports that we built were focused on payer mix and service delivery. And each of these reports were available at the agency level, the program type level, as well as the individual program level. And each report could be drilled down by diagnostic category and service type. So part of when we were working on this project, what we decided with these EHRs was that these reports were going to be available free of charge to all new and existing New York State clients of these 4 EHRs. So if you are a client of one of these 4 vendors and you've not heard of these reports and there's something you're interested in, we suggest that you reach out to them or feel free to reach out to us with questions. But again, these reports are, through these 4 vendors, built into the system. It should be available to all of their clients. And what do these reports tell me? So these 2 reports give agencies a sense of who they're serving, the types of services that they are delivering, the type of services individuals with specific diagnoses are receiving. It also allows you to break down clients by insurance type. So really a key feature of these reports that we built were was the idea of standardization of definitions. Right, so when we were building these reports with the agencies and the EHRs, we spent a lot of time figuring out how we could all get on the same page and just come up with a standard definition for all the terms that we were working on.
Thank you, Ashley. Good afternoon, everybody. I'm David Worsnick, and I'm going to take you to the next section of the presentation. We do want to start with a poll question, which should be coming up momentarily. We'd like you to take a second to answer. You should see it in your polling box on the right-hand side of your screen. Rate your current level of comfort with the process of data collection. Let us know if you're very comfortable, somewhat comfortable, slightly uncomfortable, uncomfortable, or very uncomfortable. This really helps us get a basic temperature of how people feel about their own expertise. And we'll let this run for another couple, 15 seconds or so. And then we'll ask Jocelyn to give us the results. And as we're waiting for that, the next section we're going to be talking about is something that I call the anatomy of an outcome measure. The way we decided to work this series, and probably the remainder of the series, is to take an example of an outcome measure and walk through the different aspects, first of all, of the measure, that is the anatomy of the measure, and then Ashley will talk near the end of the presentation about some of the activities and some of the processes that you need to be thinking about to be able to start collecting the data. So I see Jocelyn close this out. So we're looking at somewhat comfortable, which is very good, 44 out of the 100, and nobody really is very uncomfortable, which is a great starting point, and hopefully as we go through today, we'll help people become a little bit more comfortable. So the first thing I want to talk about is in the anatomy of an outcome measure is types. I'm sure you've seen this before, but we really talk about two types of measures. One is a process measure, and another is more of a clinical outcome measure. The process measures are really measures of specific steps that you take, and basically we anticipate that the steps that you take will have a positive impact on your consumer status or condition. Process measures, or the one that you see all the time, is the number of days after discharge from an inpatient hospitalization that it took for you to engage with the client, or the client had an outpatient visit, or the client had a visit with a prescriber. The assumption being there that the longer a person is in the community without connection back into the treatment system after discharge from hospitalization, the increased prevalence of rehospitalization. So that's a process measure, and we'll use a process measure as our example as we work through today. The other is more of a clinical outcome measure. That's a measure of change in a consumer's status or condition based upon an intervention. That should really read an intervention or series of interventions. So you may have an individual or consumer that you're working with that have been difficult to engage, has pretty poor medication compliance, has a number of ER presentations, hospitalizations. So what you do is you assign a case manager, you assign that person to your clinical outreach team, you start working aggressively with that individual in the community, you go out when they don't come in for their appointment, you work on their Medicaid management and Medicaid compliance, and you see an increase in that individual's tenure in the community. So those are the series of interventions or an intervention that you're providing that changes an individual's status. Again, the process measures are a change in your process that is assumed is going to have a positive impact on your consumer status or condition. It's a fairly important distinction. So as I said, what we're going to talk about today is the different components of an outcome measure. And you're going to see this if you've looked at the HEDIS data, if you've looked at Certified Community Behavioral Health Clinic data, PQRS data, you'll see that there's a standard kind of a breakdown for these outcome measures, including the description and the data source, measurement period, definitions, numerators, denominators, and reporting classifications. And each of these components make up your outcome measure, and we'll talk about each of these individually. So the first thing is in the anatomy of an outcome measure is the description. It's just a basic narrative description of your outcome measure. The example we're using is one of the outcome measures that individuals who are involved in the Certified Community Behavioral Health Clinic pilot project here in New York are going to be accountable to reporting to, and I picked that one because it's a relatively simple measure. It is a process measure, and it is one that is out in the environment right now. And an example here is the percentage of new consumers with an initial evaluation provided within 10 business days of first contact. That's a process measure. There's really no intervention here that you're measuring. You're measuring a time period. You're measuring how quickly you do something. The assumption is that you'll probably be better able to engage an individual once that individual has determined or made a determination that they're calling and that they would like an initial evaluation. They've made some conscious decision. They're at a phase of readiness, hopefully, and the sooner that you can get them into your clinic, probably the better you're going to be able to engage them. So it's a narrative, again, just a narrative description of the outcome measure, very simple. The next thing that we talk about is the data sources. And the data sources can be really all over the map. It's really the agency-specific source or sources of information necessary to report out on the data. So if you go back and you think of, let's look at this again. So we want to know the percentage of new consumers with an initial evaluation provided within 10 business days of first contact. Well, how might you collect, what might your data sources be for that? Well, you may have maybe you have an intake call log that you record every time that an intake call comes in. You record the day, you record, it could be any information, who they're assigned to, what day their appointment, however that works for you. You could have an electronic scheduling system that you take all your intake and record all your calls through, and then maybe schedule somebody right there while they're on the call. So you record the call, you record the date the call came in, and you record the date that you scheduled them for the initial visit. Now, those of you who have open access, you know, that's the same kind of thing, though, is that, you know, if you say to them, you know, come in anytime tomorrow, well, then you need to record that the call came in today, and you basically ask them to come in anytime tomorrow. And then what we're looking for is, if you think about the measure, it's 10 days between call and initial evaluation. So you need to know when the call was made. You also need to know when the initial evaluation was performed, and you're going to measure the time in between. So that data may come from a billing system. So one of the things that we'll be talking about a little bit later, and we'll be talking much more about on our next webinar, is that many times you're going to be faced with the challenge that data is going to be in two or more separate data sources. I think that our EHRs are robust, but we're in a developing environment of the different kinds of outcomes that we're going to have to record. So there's really no standard in the industry right now, so those are not baked into our EHRs. And depending on what kind of flexibility you have in your EHR and in your billing systems and how well, what you can configure and what you can create on your own and what you need your vendor to create, it's highly likely that you're going to have to really create data from multiple sources. Some of them will be what I call on-system, which will be information that will be in your EHR and billing systems. But I think it's likely that you'll have some off-system data collection requirements too, which might be, like in this case, a call log, an Excel spreadsheet, an Access database, a SQL database, some other set of data collection tools that then we'll talk about next time, is how you can think about bringing those two different data sources together into a single source. The next thing that we talk about in a component of an outcome is measurement period. So in this case, it's the time requirements of the measure. That is the frequency of reporting. They could be anywhere from monthly, quarterly, to yearly. An important piece here is this: the measurement period is the frequency of reporting. It is not the frequency of your measurement. It would be really not best practice, obviously, if you have to report out on a metric on a yearly basis and the only time you look at it is at the end of the year. So the frequency of reporting and the frequency of your own data collection, measurement, and analysis will be two very different things. So reporting will be sort of the back end of your process, and on an ongoing basis, you'll be looking at the report on a much more frequent basis. There could be some things that you may want to look at daily, unlikely, but certainly weekly or biweekly and no more than monthly, so you'll have a good idea of what your performance is based upon your outcomes. That, of course, then feeds back into your quality improvement program and how you use your data, and we'll be talking more about that in our last of this series. The next component is a definition. So let's look at this a little. This is a description or definition of the eligible population. That is all individuals that must be measured. So let's go back real quick and see the difference here. So we have the percentage of new clients, new consumers with an initial evaluation provided within 10 business days. Let's look how this is different. This is new consumers not seen in your program during the last 6 months with an initial evaluation completed. So the definition really defines your eligible population, and the key aspects of this particular outcome measure is that they're new consumers, and the definition of a new consumer is an individual that had not been seen in your program in the last 6 months. And the second condition is that initial evaluation is completed. So if you have somebody calls and they had been involved in your clinic as much as 3 months or 4 or 5 months ago, then they're not a member of your eligible population, and you may have to make sure that you don't include them in your eligible population. And the second caveat to this definition is that an initial evaluation was, in fact, completed. So they want to measure the amount of time from the call to the completed measure for individuals who have not been active in your clinic in the last 6 months. So here you can see we're starting to get into the operational definitions, and it's really critical as you start looking at these operational definitions is that you have a shared understanding. So you have a shared understanding of what not seen in your program during the last 6 months. So Is it the day that you did the discharge or termination note? Is it the last actual day that they were seen in the clinic? Was it the last actual day that they were scheduled in the clinic? So these are the operational definitions. What does it mean by evaluation completed? How do you define that? How do you share that definition with your staff? So something as simple as this definition of your eligible population, in each of these, you have to make sure that when you go to operationalize this, that you have a clear understanding of the conditions, a definition of what they are that is articulated to all the members or all the individuals in your organization who will be part of this workflow. There's grabbing and flagging this information correctly in the beginning will be essential. The last thing you want to do is go back and try to reconstruct or recreate data because you didn't have a clear understanding of the metric and the conditions of which who you're going to be measuring. Now we get into numerator and denominator, and the reason that we have a numerator and denominator in this outcome is because we are evaluating a percentage. Now let's remember our simple math, a numerator and denominator, and you can calculate a percentage. So what we need to do then in this metric is to understand what the numerator is. And in this case, the numerator, well, the definition, it's a subset of the eligible population that met the conditions of the measure. So in this case, it's the number of consumers in the eligible population who received initial evaluation within the 10 business days of first contact during the measurement year. So eligible population is that the individual had not been seen for the last 6 months, so that they've met that condition, and in this case, they had the initial evaluation within 10 business days of the first contact during the measurement year. So again, the numerator is the subset of the eligible population that met the condition of the measure. Of course, with the numerator, you always have a denominator. So the numerator is those who were successful, and the denominator is the total number of consumers in the measurement population. So that's the number of consumers who received the eligible folks. So a simple example of this is over the last month, you had 100 individuals contact your agency. Of that 100 individuals, none of them had been seen in your clinic in the last 6 months. That is now your eligible population. And in that month, out of those 100, 90 of those individuals had a completed initial evaluation within 10 business days. So your metric is simple, 90 over 100, 90%. You're at a 90% rate of meeting your outcome expectation. So it's really, what drives the numerator and the denominator is that we're now looking at a percentage. So that's actually then as we begin talking next time about what your outcomes are going to look like, how you're going to monitor them. The outcome is relatively simple on this one. It's going to be a percentage. And we're going to take that percentage and compare it to our goals. So the final part of the anatomy of the outcome is the reporting classification. That's reporting rules that require the metric for subsets of your eligible population. And it's normally not going to be as simple as okay, report this for everybody who walks in the door, because your outcomes are going to be driven by payers, it's going to be driven by New York State, it's going to be driven by federal government, it may be driven by your districts, and they may all be interested in different populations. So you may have to report them, say, by payer. Here's something to consider, though. So say you have a metric, say it was this metric, and you had to report it only for your Medicaid clients. One question that you have to ask yourself is that if you have commercial insurances, do you want to really segregate and only report, maybe you need to report on Medicaid, but are you going to collect outcomes just on Medicaid? Might it be worth your while to count that for all of your clients, or all of your consumers? So at some point you can go back to your commercial vendors and say, hey, look, we're getting 100% of our folks in this time period, and that becomes part of the way that you talk about your value. So you may be required to report by payer. You may also be required to report by age. So in this example, what we have is that we have the percentage of new consumers with initial evaluation provided within 10 days that are between 12 and 17 years old. The other component would be that is the same metric, but that you have to segregate and report on individuals who are 18 years or older. So what you have to do, and we'll be talking more about this as we go forward, is that you have your metric. You have to know when somebody called. You have to know when they had an initial evaluation completed. You have to know if they've been seen in your clinic in the last 6 months, and you have to know their age. The art is going to be, and the science is going to be, how you take those different bits of data that may be living in different places and bring them together into a coherent and accurate data set that you can report out against. And that's really, in many, I think, is going to be the primary challenges that we're going forward, and next time we'll talk a bit more about some of the tools that you may want to use to help you with that challenge. So before I hand it over to Ashley, we have another poll question. Jocelyn, you want to fire that up for us, please? All right. Do you have a set of the outcomes that you're currently measuring? Yes, we definitely have a set of outcomes. No, but we're working on it, and we have not started yet. So let's take about time that it takes you to click a checkbox and a radio button, and then we'll see what folks have to say. Five more seconds. Okay, Jocelyn, let's turn that off and see what we've got. Anybody wants to write to WebEx and tell them they really need to speed up this? Okay. Yes, we definitely have. Well, that's a good 43 out of 120. A bunch of folks didn't answer. So it's really hard to tell given the number of folks in, but about half and half between yes, we definitely have, and no, but we're working on it. Not very many people have not started yet, which is great. So what I'm going to do is I'm going to hand this back to Ashley, who is going to work on the rest of the presentation, and then I'll be back with you for questions at the end. Ashley?
Thanks, David. Okay. putting the pieces together. So using the example that we've been using, what I'm going to do now is just walk us through a quick example of how we would actually do this. So we're going to break it down into four main steps with some sub-steps within each step, I like to say. So our 4 steps using our example, and again, our example being the percentage of new consumers with the initial evaluation provided within 10 business days of the first contact. So the 4 steps: step 1, figuring out your denominator; step 2, figuring out your numerator; step 3, marrying your data for reporting and analysis; and step 4, to process the changes. So step 1, our denominator, right? So collecting data on who your eligible population is and asking ourselves the question of who are these people and how am I going to identify them? So who do I need to identify, right? For this example, it's all consumers who contact the agency requesting an initial evaluation who have not been seen in the agency in the last 6 months. How am I going to identify them? Determining what method is going to be used to record on what day the consumer contacts your agency for the evaluation, and how you're going to know whether or not they've been seen in your agency for the last 6 months. Then you're going to have to evaluate and ask yourself, what do you currently record when a consumer calls for an initial appointment? And how are you going to determine if the information you need is already being recorded and is available for reporting? So you ask yourself the question, what am I currently doing? Is this going to work? If yes, great. And if not, asking yourself, what changes to your process do you need to make that will ensure that you can capture the data elements that you need, right? So if you need to capture the data of the call, your initial evaluation requested, but really, again, to David's point before, being really mindful of how you're operationalizing and how you're defining these terms. Then we're going to determine, so if not, then we have to determine what tools you're going to use to capture the information in a manner that can be easily translated into numbers. So maybe you're going to use your electronic scheduling system, maybe you're going to build a call log out of an Excel document, your notes in your EHR. But again, it's putting the tools and the process in place that you can draw upon these numbers when needed. Then we're going to make sure that our workflows are in order. The workflow will help us assure that the information that is being recorded is being done in an accurate and timely way. Right? So making sure that the roles are clearly defined and knowing who it is at your agency that is responsible for recording each of the data elements that are going to be needed. So after we've figured out our denominator, the next step will be to figure out our numerator, which again is the subset of the eligible population that met our measurement requirements. So again, it's asking the who and the how. So who, it's all of those who had successfully had their initial evaluation completed within the 10 days of the initial contact. And the how, of what method are you going to use to record if a consumer received their initial evaluation or did not receive their initial evaluation. Again, then we're going to evaluate. The where and how the data elements you require are recorded. How are you going to document if the initial evaluation was performed, the date, if the consumer was a member of the eligible population, and the age of your consumer. Then we're going to determine what tools you're going to use to capture the information in a manner that can be easily translated into numbers. Again, whether it's from your EHR or your billing system. And then similar to before, making sure that our workflows are defined, that we have this information collected in a timely and accurate way. So our third step is marrying our data or creating our data source. So bringing your data into a single source for reporting and analysis. So it's possible and probably very likely that the data that you need for your numerator and for your denominator come from different data sources. So you'll need to have enough information about each consumer in your eligible population to match that individual's change in status or condition across your different data sources. And as David pointed out before, in the next webinar is going to focus or spend some time focusing on how we can create these data sources and bring data from different places together so that we can report on them. And our last step, step 4, is to process our changes. So to ask ourselves and determine if our current policies, procedures, and processes that are in place are sufficient to meet your outcome target goal. So deciding what is your target outcome goal. Is it 100%? Is it 98%? Is it 90%? Et cetera, et cetera. And based upon your goals, determine if your current processes will ensure that you will meet your goals. And if not, making the necessary changes to whether it's staffing or expectations or to our processes so that we can get to meet our goal. And monitoring our results to make additional changes when necessary. So to David's point before, if we wait till the end and then figure out that it's not working, it's going to make it really, really hard to go back. So it really is important to monitor your data and your results over time so that you can make changes as needed. I'm going to pass.
Thank you, Ashley. I think that the last point that Ashley made is pretty critical in that we have all kinds of processes in place. We do all kinds of things, and for each of the outcome metrics, we're really going to have to ask ourselves that critical question is, if what we're doing now, will it be sufficient? Will it be sufficient to meet our goal? First of all, setting your expectation goal realistically. It's not going to be 100% all the time. In some cases, it might be. But in other cases, that may be a very difficult benchmark to set. Those benchmarks could be set by the individuals who are requiring you to report. So that might be different. But again, take a look. What is the process that we currently have? What are the workflows that we have in place? Do we believe that it's sufficient? One of the ways you may test that is that you could maybe pull some sample data, say sample data, pull all the initial contacts that you had prior to your reporting requirements and match those up against all the initial evaluations. See what the time frame was between that. Did you meet that 10-day goal? If you did you meet it? What is your goal? Is your goal, is it good enough that you're 100% on that? Do you want to drive that down to 2 business days, 1 business day, the same day? Be thinking about your practice. Just because you're making your outcome metric, that doesn't necessarily mean that it is the goal that you have for the organization. You may see that as an important metric, but you may believe that you should have people coming in much more quickly. Your goal may be, you may have direct access or immediate access. Your goal might be next day, and that would be great. So your outcome metric would then see if that you're actually meeting that goal. And if you're meeting that goal, you're certainly going to meet your 10-day goal without a problem. So there's a lot of activity that needs to go on. We've got a couple of minutes yet before we stand up our questions, so I do want to talk a little bit about our next presentation. I think that's one of the things that, again, I think is going to be the greatest challenge for us moving forward is that data is going to be in different sources. It's going to be in Excel, it's going to be in Access, it's going to be in SQL databases, it's going to be in proprietary databases in your EHR, it might be on paper, it could be buried in case notes in a text format, it could be in information that was scanned into your EHR, it could be structured, it could be unstructured, it could be really anywhere. And you really can't sit there and have a process where somebody has to manually look at data, line it up, make sure that you've got your numerator correctly, your denominator correct, and then figure out the metrics. You're really going to have to figure out a way to automate the process. And one of the things that we're going to be talking about next time is some of the tools that are available. They're really being called business intelligence tools. There's a series of tools that allows you to be able to point to data in different data sources, in different places, bring them together, create sort of a single data table or a single data source that has all the data elements in it that you need so that you can create these metrics accurately and simply. Now, it's not going to be a hands-on series or presentation next time. We really can't show you or instruct you, make you into professionals in a 45-minute presentation, but we will be talking about some of the challenges and some of the tools that are available. So with that being said, Danielle, do we have any questions that came through while Ashley and I were talking today?
We do have a few questions, and while I am reading out those questions to our presenters, again, I just want to encourage folks to chat in their questions using the chat box and sending them to all panelists. So we do have a couple questions. Like I said, the first question is, I guess, really a suggestion or seeking suggestion. They're asking, what would be the best EMR to use when collecting data?
I'm sorry, I didn't mean to chuckle.
Good question.
And it's a very good question. All I know is that there are very few people who are absolutely happy with their EHR. That being said, there's a lot of folks out there. I guess what I would look at in an EHR to be able to address these outcome questions is, or need for collecting data, is what flexibility do you have in the system to create a data collection tool? So some of the EHRs will allow you to build an assessment yourself. And so you could build an assessment, or you could build a tool in your EHR that you can then use as a data collection tool. It's written to your database, and then it's available for you to query. So I would look, when you look at EHRs, I would look around flexibility in terms of creating or configuring, really creating your own data collection tools. The other thing that I would look to is ease of getting the data out of the system. So how easily can you shape your EHR for getting data into your system, and how easy is it for you to get data out of your system? I talk with people all the time who are sitting on a load of data in their EHRs, in their billing systems, and they really don't know how to get it out. There's really two methodologies well, there's actually three methodologies for extracting your data. Canned reports, Ashley talked about some of the work that had been done last year to create some basic reports with shared definition to help people understand their populations better. So look inside of your HR, what reports do they have, and that are canned, that you can begin bringing data back out. Certainly the requirement would be that you bring that out not in printed form, but in a CSV format, which is a comma delimited text format, or an Excel format, or to some other format that you can access. So the first thing to look at in your EHR is what are the kind of reports you can get out of the system. The second piece would be to ask yourself, what kind of report generator does the system have? That's what we call ad hoc reporting, where you can go in and you can point to your database and you can select the data elements that you want, you can select the filters you want. So you could write a report that would go in and maybe look to your scheduling system and tell you when each appointment initial evaluation was scheduled, and then would look to your billing system and tell you when that initial evaluation was done. And you could generate a report that would bring that data out. Most of the EHRs certainly have report generators, ad hoc reporting. That you really need to take a look at that. If you don't feel sufficiently trained on your report generators in your EHRs, then I would go back to your vendor or to your user group if there is one. You need to train somebody up. I mean, you can't sit on that mound of data and not be able to get it out. So if it's a lack of training and understanding of their tools, my recommendation would be is that as soon as possible, you begin the process of getting folks trained up in your organization to use those tools. The last methodology for extracting data from your systems would be actually a direct data access. There are tools inside of Excel that you can make a data connection. If your EHR uses a standard database, a Microsoft SQL database, and you can build a data connection directly from Excel into your data behind the scenes and do your own ad hoc reporting. You can query your data, you can filter it, you can transform it, and we'll talk a little bit about that next time. So as you begin evaluating EHRs, it's what's the flexibility of getting your data in? How easy is it to get your data out? And is there a possibility to connect directly? And you won't find me recommending one EHR over another because it's, like I said, there's so many different ones and different needs, and it's really hard to pick one that really stands out above the rest.
Okay, thanks, David. We have a couple more questions. The next question is about the example that was used throughout the presentation. So why 10 days? Isn't the requirement 14 days?
This was taken from the CCBHC metrics, the Certified Community Behavioral Health Center metrics that were required of reporting, and so that was the 10 days. And it's just as an interesting caveat is they don't care if a consumer says, no, I can't get in within 10 days, put me in 2 weeks. That still would be an individual who fell outside of that 10-day period. So the expectation is that you do whatever is necessary to engage that individual sooner. But I didn't make I just pulled that from the required metrics.
Okay. And then the next question is, it sounds like it's related to health home participants being in the MAP portal. So I'm assuming the question is being able to pull data from there. It just says, aren't most of these participants already in MAP?
Aren't most of these participants already in MAP? No, not necessarily. You know, your MAP data is primarily if you have access to that data, you have access to that data as a health home. Those are not necessarily everybody who will be treated in consumers that will be treated in your organization will have a health home case manager. But it does raise an interesting question about other data sources. We're involved with a health home. We access that health home, that MAP data, and it is a huge wealth of data that we use for all kinds of analysis and our own internal outcome measures. There's the psyches data that's out there. New York State reports data on ACT teams and pros, and so it may not, the data that's specific to an outcome may be in a different data source that you have access to. So don't forget to look outside of your own sort of environment. at the very least, some of that data gives you an idea of how well you're doing in other areas. It will give you an idea of what your population looks like, some of the demographics, maybe even some of the diagnostic categories. One of the things that's important as you begin looking to reporting outcomes, and as we move into value-based, we're really going to be more of a population management-based view of the world. And so I think that other data out there in the world is probably very helpful for you to gain a better understanding of your populations and who you're serving, and that I think is an important piece in thinking about your processes and evaluating your own outcomes. Anything else, Daniela?
Yeah, well, a couple more questions just popped up. Any suggestions about how to identify what's most important to measure, which sort of goes with the next question of can you suggest any basic outcomes that you would measure across different service providers? Maybe we could put those together.
Two things together. Well, I think that let's start with the last presentation that we did really tried to focus and helping you focus your thinking on what are the outcomes that you want to start measuring. And we took a look at that based upon value proposition, what value do you bring, and also what might be requirements from other sources. So if you didn't have an opportunity to take a look at that presentation, it's recorded. I jump back and take a look at that because we focused a little bit on that and how you decide to measure what matters. I think on a general way, I mean, some of your outcomes are going to be required. Like I said, we brought this right from the CCBHC model. Those are required outcome measures. So part of those are going to be defined. Certainly what the entire field is looking at right now are around engagement, client satisfaction, inpatient hospitalizations, ER presentations, those kind of things. I would look not only to your value proposition, take a look at some of your local districts. You know, we're moving into a value-based phase with the districts. If you're involved with a district, reach out to them. What are their outcome metrics going to be? How should you begin thinking about that? But focusing right now, and the other piece of this is going to be consumer satisfaction, because you know part of what everybody is looking at is really the experience of care, and that being an important aspect. So you can't go wrong with starting about measuring the experience of care for your consumers and their satisfaction. You certainly can't go wrong in looking at if you work with individuals who have inpatient hospitalizations or ER presentations, as do you have interventions that are designed to affect that. How quickly are you seeing somebody after they've been hospitalized? How quickly are you seeing somebody after they've had an ER presentation? The other piece certainly that they're looking to is integration with physical and behavioral health. Some of the metrics that are seen in CCBHC are around BMIs, you know, our alcohol cessation, smoking cessation, kind of what kind of work are you doing to assure that you are addressing the co-occurring physical health needs of your consumers? I think that those probably, if I had to conceptualize what I'm seeing most out there right now, those would be the kind of things that folks are most likely focusing on. But again, I would, you know, a district would be a good indicator. There's some new stuff coming out on value-based and performance-based contracting in year 17 measurement. There's some stuff out on the OMH website about that too. So, you know, just sort of start fishing around, keep your ear to the ground, read what you can, talk to folks, and I think you get a really decent sense. A lot of people are talking about the fact that, you know, we don't know where to go yet. I think there's pretty clear paths about what we're going to need to begin thinking about. And at the very least, you can start building your infrastructure now, thinking about, your AHR, how you're going to connect, what are your data tools, aggregation, analysis tools that you've got in-house, who you're going to need to training more people, those kind of things that can be issues that you can start addressing now also. Anything else, Danielle?
Yep, there's one last question that just popped up in relation to psyches. They're asking who has access to psyches data and who can have access to psyches?
Ashley, or Daniela, do you have the answer to that question?
I don't.
All right. It'll be an easy enough thing to do. So let's do that. Daniela, we'll do that research. We'll get that information, and we can either answer that in 2 weeks when we do our next presentation, or if there's some other methodology that you have that you can post to answer that question.
Yeah. So this person who sent the question in, as long as her email should be attached to her registration for today. So we can go ahead and just, we'll send you that answer through an email, okay? We don't want to give you the wrong information.
Yeah, I don't, I agree with that 100%.
I'd rather do a little research to get the right one.
All right. So, if there's, I'll let you close out. Thanks, everybody. Go ahead, Danielle.
So if there's nothing else, we just want to thank everybody for participating, and hopefully we'll see you in 2 weeks so that we can go through some of those business intelligence tools with you in Excel. So just a big thanks to David and Ashley for today. Thanks so much. Have a great day, everyone.
Thank you, Danielle.
Thank you.